My name is Torrin Wilkins, the Director of Centre Think Tank, and I'm joined by Nancy Burge. We'll be discussing the system of assisted dying used in Western Australia. Nancy graduated from University College London in 1982. She then worked as a general practitioner in Brighton and then the Isle of Skye before moving to Perth in Western Australia in 2015. She was among the first doctors to undergo training when Western Australia legalised assisted dying. So thank you so much for joining me today, Nancy.
You're welcome. You're welcome.
So, for my first question, any system that provides assisted dying also needs to detect any cases of coercion that might exist within that system. So, what measures are used within your system to do this?
Well, this is actually quite an interesting question. When assisted dying went into became practical in Australia, all doctors had to do some quite difficult training. We had to pass a number of modules to make sure that we understood the systems. And one of the issues was, how do you detect coercion? There aren't actually any tools for detecting coercion. And that was one of the things that's specified in the training, that there aren't any particular tools. But there are things that many of the VAD doctors are GPs, certainly in Western Australia, maybe not in other states, but I think we generally are good judges of character. Um, I haven't come across any instances of people being coerced. In some ways, it's the opposite, in that you might get a couple coming in and one person wants to know or access assisted dying, so they're asking all these questions, and the other person actually doesn't want them to access it because they don't want to lose their loved person. Um, I think that if we had any concerns about this, we would actually try and speak to the person on their own. We would ask them if we could uh, ask their other person, their spouse or family member or whatever, if we could speak to them alone and just try and suss out the situation and what was going on. The interviews that we do for assisted dying, they tend to be quite long because there's a lot to cover and people want to ask questions. So I think you do get a sense of really what's going on there. I haven't had any cases where I've been concerned about coercion. Um, I had a couple of patients who were both lawyers, and the first thing they came in and sat down, and the first thing that the wife said was, "Shall I go out? Because I understand you need to see my husband on his own." And I said, "Well, yes, I don't need to, but I can ask if I have concerns." There was clearly no coercion going on there. I think as doctors, experienced doctors, you can have a sense of what's going on. And if there was coercion, I think we would have that sense that something was not right and would delve further.
So, in terms of the past cases that you talked about, is that when people are worried about, say, a loved one who would like to use the assisted dying system and maybe don't particularly want them to, would you say that that was sort of coercion or more just that they had quite large concerns about them doing that?
Well, they're not coercing them not to have it.
Hmm.
Usually they'll say, I do support them, but I don't want it. I don't want them to do it.
Yeah.
Um, I have had a case where somebody didn't want their spouse to know that they were accessing it, and that was very difficult to work within those parameters. Um, I think it's usually been a religious objection. It's been a Catholic who has not wanted their spouse to use voluntary assisted dying because they've regarded it as suicide.
Hmm.
And that's an ethical thing, and you can talk about it. And the statewide care navigators are often very good at talking people through and giving support to family members who are not keen on the idea. But at the end of the day, it's the individual's choice, and their spouse doesn't have the right to say no.
And in terms of the spouse knowing about the process, so as you mentioned, there was a case where someone didn't want their spouse to know. Is that a possibility? Are you able to do it without
It's
relatives?
well, I ended up passing this case on to someone else because I didn't have the time to go into it in the depth that was going to be needed, but it would be very difficult. I think in the end, the person thought that they might end up going into a hospice and would be able to access the whole process at that point. But obviously it depends how fast their deterioration progresses. But it is very difficult, and nobody wants to be involved in subterfuge. But at the end of the day, I think you would try and do everything you could to facilitate that person's wishes. But they'd have to accept that there were certain constraints and it might not be possible.
So how do you pass on a report? Is it something where you would say pass on a report that say you had concerns about someone in, I suppose for you, almost the hypothetical situation that you did have sort of serious concerns, or would it be something you dealt with yourself?
Well, in part, in the process, if I took on a patient and I was their coordinating practitioner and I was doing the first assessment, and so you're looking at age, eligibility on residence grounds, and then capacity and so on. So you go through all those things. And if you had concerns about coercion, I would probably not want to just complete the first assessment there and then. I would say, look, I'm really not happy about this. I need to talk to you further. And then in the first assessment, I would have to decide if they thought they were eligible or not on coercion grounds. And if I said no, the process ends there. I mean, the other thing that I could do is hold fire, say, right, I'm not going to make a decision now. I need to think about this. I need to think about what else I could do. We'll have another appointment in a week, say, and then I could consult with colleagues. I could consult with the VAD board. I could consult with the statewide care navigators. I could try and get a consensus of thoughts about how to proceed, because okay, it's been going on since 2021, but there are still new situations arising that we haven't necessarily come across. And sharing that burden of uncertainty with other people can be really helpful.
So in your experience of the service, how helpful are those? I mean, I know you just mentioned them, but the statewide care navigator service and the statewide pharmacy service to both patients and providers?
They are actually the backbone of the service. I actually made some notes and then I actually rang them up today to talk through all the things that they did. And there's things that they're doing in the background that I didn't even know about. So we'll start with the statewide care navigators. They may be the first port of call for any patient who wants to find out about voluntary assisted dying. Not all GPs or consultants, specialists are on board with this, and everybody obviously has the right to refuse. So they may just not want to discuss it. So the statewide care navigators, or the NAVs as we tend to call them, they know who all the VAD doctors are in all the various areas, the various suburbs and places in Perth. They actually cover, I mean, Western Australia is huge. It's 100,000, it's about 1 million square miles. Obviously, most people are centred in Perth, but there are some very, very rural, far-flung places. So they will support people and find them a practitioner. As you go down the process, they will also find a consulting practitioner, which is another independent practitioner of part of the process. If there's somebody in a very rural or remote place, they run something called the Regional Access Scheme. So there is funding available to either fly a doctor to that patient in the back of Beyond, or to fly the patient down to where there's a doctor. So there is funding for that. The idea being that everybody in Western Australia should be able to access the same services for VAD. And obviously most practitioners are centred in Perth or some of the smaller towns. But there are obviously requirements for people all over the state. They provide tremendous support to the family, provide education to the family, to any of the relatives that may want to ask. They provide tremendous support to us as VAD practitioners. I mean, when we started, we were all fumbling our way through this new system, and they're incredibly supportive. They are really very wonderful people. I can't say that enough. For the rural people, or people who can't travel easily to have a face-to-face visit, they will visit that patient and set up a video link. Not all consultations during the process can be done by video link. Some has to be done by face-to-face because of the particular part of the criminal code, which means that you can't discuss the actual substances and access them by video. It has to be face-to-face. But for some of the consultations, they can set up the video links. The other thing they do is they provide education all over the place to GP surgeries, to nursing homes, to hospitals. They link patients into other services. So if they haven't got access to palliative care, they can link them into Silver Chain, mental health or aged care assessments. The other thing that they do for me, which I find really useful, is that sometimes they will access medical evidence. So if I'm seeing a patient and I'm not sure whether they're eligible on medical grounds because of their prognosis, they will sometimes reach out to the patient's specialist and get notes. Obviously, the specialist has to agree, get notes, recent letters from the hospital and so on. And that can be really useful as well. So they do an awful lot in the background. They are a bunch of amazing people. There are physiotherapists, nurses, social workers. The other thing that they can do is that they can assist if someone wants to take the oral medication themselves and they want someone to be there, then they'll do that. Some of them who are nurses can pronounce life extinct, which can be really useful as well. And I think that was, yeah, so they do an awful lot of different things that can be really useful. They also provide bereavement advice after the person has died, which is hugely important. I think that was everything. I did have a list because there's so many different things that they do. Yeah, I think that's probably it. Yes. And then the statewide pharmacists, again, hugely important part of the service. I mean, you'd think they just sit there in their dispensary and dispense the stuff, but they give help to us for writing the prescriptions, which are very specific. They have to be handwritten, absolutely 100% perfect. If it's logistically difficult, they'll often pick up the scripts from our surgeries. They obviously deliver all the medication. There's my little list of things. Yeah, so not only do they dispense it, but they support practitioners. They debrief afterwards. They give training and education. They set up cannulation workshops so that people who are not sure about doing the injection part of the practitioner administration can practice that. They also provide an on-call service, so they can deliver medication, the logistics at different times. They will deliver the medication all over the state. So that could involve two of them visiting someone in most of the far-flung corners of the state. And the other thing that I found that was quite really helpful and beautiful is that they know that they're often going to be the last health professional that person sees before they take their substance. So when they deliver the substance, so if somebody's going to access the oral substance and take the drink at home, they will deliver it to them and they will have a run through about how it's made up, because you have to mix it, shake the substance up and then drink it. It's 30 mils of a certain liquid. So they'll go through that so the patient knows how to unscrew the bottles, knows exactly how they're going to do it. They'll go through the actual protocol of the timing, because the person has to have an empty stomach, so not to have eaten for so many hours beforehand. There are also adjunct medications that they take to make sure their stomach empties properly. And there's some calming medications and some anti-nausea medications. So they go through all that. But apart from the medical side, they also make sure that the person that the person and their spouse is going to knows who's going to pronounce life extinct so that the funeral service can come, knows who they've thought they're going to ask to do the medical certificate, thought who the funeral home is, thought about how they're going to actually do this. Are they going to have music? Who's going to be there? So it's a huge thing that they do when they visit. It's not a quick in and out. They can be there for a long time. And if the person needs a rerun 6 months down the track because they haven't accessed their medication, they'll go back and do the same thing. So, they both of them are an absolute backbone to the service. It would be nice to think that us doctors would have all the time to do this stuff, but we haven't. So they are a really important part of the service.
So I was really interested on the pharmacy service specifically. So one of the first interviews I did in this, I was speaking to someone who was a sort of more rural doctor, and they were describing it as sort of a relatively invisible service, as in that the actual pharmacy service did a lot of the behind the scenes work, but they didn't have a huge amount of actual interaction with them. So did you find the same thing, that it's very much something that's really amazing at helping those going through the process? But do you see a lot of them in that process, or is it very much that?
Well, I talk to them. I've talked to them.
Yeah.
And sometimes we always think that VAD is not going to be an emergency, but sometimes it is, because somebody who's going through the process suddenly deteriorates and then they want to speed things up. And as a GP, I'm not always free to react in the way I'd like. So if I've got to write a prescription, which is, it's going to take me a good half hour to do, then I've either got to put it in the post, or I've got to by registered mail, or I've got to get it to the pharmacy. If they're coming up anywhere near my surgery to do some of their other stuff, they'll actually come and pick it up, and they'll actually check it's correct, so that if there's any mistakes, we can correct it there and then. At one point, I'd had some elective surgery and I was off, so I was at home, and there was a problem with one of my prescriptions. They actually came to my home and sorted it out. And I think they've just been really, really supportive, really helpful. Obviously, the people that work in the service believe strongly in the rightness of this process and are very helpful in that sense.
So in terms of guidance within the process more widely, what kind of guidance exists for medical professionals and more widely those involved in the process? And has any guidance or regulation sort of particularly stood out as useful for yourself in the process?
Well, when VAD came into practice, anybody who was interested had to do the training. And the training consisted of a series of modules. And I actually found them quite difficult. It wasn't the medical side of it. That's quite straightforward. It was the legal side of it. And, there is a protocol that has to be followed. It has to be followed pretty closely. You can't fudge any of this stuff. It has to be done right. The training, I think, was actually really useful. In the early days, there was a little email group of local Perth doctors that we'd met, and we talked about things, and we had a little email discussion. So if there were issues that we weren't sure about, we could talk through. 3 years on, we've had to do the training again. In terms of the legal aspects, I've actually used the VAD board sometimes for advice. I had a patient who it just wasn't clear whether, he was clearly a WA resident, but we didn't have the necessary documentation for all kinds of complicated reasons. So I spoke to the VAD board at length about what we could use as evidence. And at the end of the day, it was down to me to decide. And as long as I documented in good faith that I had extensively researched and found as much as I could, and that my belief was that this person was a WA resident for the legal requirement side of it, then yes, that was actually quite helpful.
I'm interested in sort of the training that you've gone through, and sort of what it's like when you go from, being someone who's a GP to then going, I would like to join this system. I would like to become a sort of VAD practitioner. And then what's that training like afterwards, both as the system, but also your sort of personal response to going through that training? And one person said to me, it becomes a reality kind of thing. What's that like?
Well, it was something that I'd always believed. I always believed that it would be right for someone to be able to choose the time of their death if they were really suffering. And I have obviously been aware that palliative care is really worthwhile. But there are some instances where palliative care just can't fulfill the right things. And there are some deaths that are very painful and unpleasant. And so as soon as it became clear that it was going to become legal, I thought, right, I have to put my money where my mouth is and do the training. And I think we all found it quite confronting to start with, because these were conversations we hadn't had before. But having said that, as GPs, we're used to having difficult conversations. We're used to asking people deep, meaningful questions about things that they might not want to share. So in some ways, that stood us in good stead. The handbook that came with the training is like 185 pages. And every time I would take it with me so that I could check. And there are templates for the things that we have to fill in, because everything that we do, we have to fill in online for the VAD board. So I would make sure I had all the questions and answered all the questions, then I'd go back and log it all. I have found it incredibly satisfying work in that the responses I've had from people and their families have been amazing. People see VAD as an escape route, and they see the possibility of a really horrible death that they can escape, and it gives them autonomy over that. They can choose. And sometimes I get notes. I've been given bottles of wine and all kinds of things after people have died, because their family have appreciated what's happened. And I this care navigators and the statewide pharmacy, they're the same. The thanks that people give is tremendous. That's why I do it, because it's important.
So, of course, some organisations and charities are of the opposite view. So they may be either incredibly opposed or incredibly in favour. And the settings may include at home, in a hospital, within a hospice, when speaking to their GP, or with family and friends.
Right.
How do we make sure that people do feel comfortable asking for or rejecting an assisted death?
I think that this has always been a problem. Some of the religious organisations have been opposed to voluntary assisted dying right from the start. We had a big meeting many years ago before voluntary assisted dying came into law, and there were representatives from a number of these organisations, and they were really put on the spot by the questions. And they said, well, we will not put obstacles in the way of someone who wants to access it. But in fact, in practice, they do. For instance, many of the public stroke private hospitals are run by religious organisations. And so if you're in one of those hospitals and you want to access VAD, I'm not allowed to set foot in that hospital. However, they will allow the VAD navigators to set up a video link, but I'm not allowed to set foot in that hospital for those purposes. So it can be very difficult. There are many people who oppose VAD, and if you're a GP and you oppose it, that's completely all right. But you do actually have a legal obligation to say, no, I'm not part of this, but this is where you can get the information. But sadly, that doesn't always happen. I know that in Victoria, when they set up their legislation, it was not people, nurses and doctors were not allowed to raise VAD. They had to wait for a patient. Well, that's how they're going to know about it. A doctor or a nurse practitioner can raise it, and they certainly do. So, when you have someone who's got a serious diagnosis, you can mention that this is an option. I mean, I might mention it, but I wouldn't say, oh, I'm a VAD doctor. I would just say, are you aware that this is an option? And I have a number of colleagues who've mentioned it to patients and said, there's a VAD doctor in our practice. If that's the route you want to go down with, let me know and I'll put you in touch. There was a lot of media interest when it became law originally, which has died down. And I find it extraordinary even now that people sometimes have no idea that it exists. And they ask their doctor, who might say, no, I don't know anything about it. And they just don't know where to turn. And I don't really know what else you can do. All you can do, I think, is talk about it. If people ask me about my job, I'll tell them. I've told my hairdresser all about VAD, and she's had a most fascinating conversation, knowing all about it. Now she talks to a lot of people, so she will, talk to people at some point and say, "Oh, I know about that."
Mm.
I've just always been open about it because I think it's important.
Yeah, I find that really interesting. I mean, another conversation that I had was about, that idea of getting it out there, and the idea. One of the ideas that was put forwards was this thing of, when you go to doctors' surgeries and stuff like that, they'll have all kinds of other posters and leaflets and everything else about lots of other services. But he
Not
said,
about this.
but not about this. And so would that
see
help?
I
Yeah.
don't think we've got any.
Hmm.
I don't know. I mean, originally, on the website for the practice that I work on, I've got a little bio
Hmm.
about the things that I do, but I haven't put VAD on it. And maybe I should. I don't know.
So it's
It's
part of
interesting.
it. It's about getting rid of, I suppose, you could almost call it the sort of stigma around the actual process as well, because it's quite. I mean, obviously, when these debates are going on as they are in the UK, I mean, there's this big debate about should it be legalized or not. But then it's really interesting that even once it's become law and it's become legal that assisted dying services exist, that actually it still takes time for
Yes, but
society to
then
catch up.
if you think about the number of people that actually need it, it's probably relatively small.
Mm,
So it's just not mainstream media, is it?
mm.
I don't know what the answer is. I just talk about it in anyone that asks me, to be honest.
In terms of liability within the process in Australia, particularly for doctors, what level of responsibility do individuals like yourself have within that process overall?
What, within the legal process, do you mean?
Yeah, so within the legal process, but also on a day-to-day basis. So sort of that thing of having both liability, but also just the general responsibility that being in the process involves.
Uh, well, when we did the training, one of the things that it was made clear was that if you worked within the law,
Mm,
so you were generally abiding by the rules, etc., etc. If you made a bureaucratic mistake, but it was in good faith, then you would be protected within the law. And that's happened. Like, we ended up with somebody, and in the system, I'd done one report. The consulting practitioner had done a report, and the two dates of birth didn't match up. Well, clearly, we weren't trying to fiddle anything. And
yeah.
once we got it sorted out, they amended it, but they picked that up. The timing issue, some of the things they have to be with us, there's a time limit. They have to be more than 9 days. If you'd made a mistake on that, but it was a genuine error, it wouldn't matter.
Mm,
There was there was a case actually where a doctor made a falsification on a document to do with VAD, and it was something to do with changing a date and backdating it, and he actually got fined a lot of money.
mm,
And there was a sort of big outcry at this because they were saying, well, he didn't mean to do anything bad. But the point is, it's a legal process which we have to follow. You
mm,
can't fudge it. If you fudge it, what else might you be fudging? You've got to stick to the rules. And I think that we've all been clear about that. And I think that was one of the things when we did the training, the medical side of it was relatively easy because that's what we're dealing with all the time. We
mm.
have to be clear that we're doing the legal stuff correctly. And so for instance, the written declaration, at one point, the patient has to make a written declaration. It's a form that they have to fill in and they have to fill it in correctly. And if it's not filled in correctly, you can't accept it. You have to go back and get it right.
Mm.
You know, do you know what? You can't say, oh, that they made a mistake, let's cross it out. I had one person who their signature, the way they made their signature had a line through, which looked as if it crossed it out. I actually had to check that that was their signature. And I actually had to make a note that it was not crossed out. This was how they signed their name. So, and as long as you cover all the bases, I think that's fine. But on a day-to-day basis, I don't really know what you mean on a day-to-day basis.
So that was more sort of the responsibility that you feel within the system. So, of course, you're dealing with people going through that process towards the end of their lives. So, do you feel sort of aside from the general legal side of things and having to deal with a sort of legal framework, just the responsibility that you feel towards the families, towards the people going through the process, and how
Oh,
does that?
yes.
How does that? I suppose almost.
Oh, yes, more sort
Yeah.
of personal thing. Yes, I do. I mean, I think that palliative care, anything at the end of life is hugely important to get right. And I would often like to spend more time with people. I do. If somebody's coming to see me in the surgery for the first assessment or the first time we meet, I will try and make sure that it's not like 9 o'clock and I've got somebody booked in at 9:30. I'll try and my receptionist knows this. So, she knows it's a VOD patient. We'll put it at the end of the morning. If it runs late, it runs into my lunch hour or my catch-up time or my admin time. So I'm not keeping someone else late. So it gives me the time to spend with that patient as much as they need. And the process, when you look at it in the way you're supposed to do this, then that, then that, then that, it doesn't happen like that. The first thing they want to know is, how do I access it? Is it a pill? Is it an injection? So in some ways, the first time you see them, it's a massive amount of questions. It could be all sorts. And you have to go with that. You have to provide all the answers. And I do take it very seriously. I find that you make quite a connection with these people quite quickly because it's very deep and very personal, quite emotional. I always hug them because I think we both need it. And I often say to them, can I give you a hug? And they say, oh, yes, please. Because it's really important. Yeah, it is important. It's very important to get it right and to do it right.
And it feels like a lot of it is that sort of the personal side of the service as well. Again, as we often are talking about, regulations and rules and everything else, but a lot of it feels like it's that basically that human side of the service and trying to make sure that person.
I mean, sometimes they're my own patients that I've known for years. Sometimes they're not. But there's one interesting little aside. I had a patient who actually was a lawyer and his wife was a lawyer. And they were the two people who'd actually read the act from beginning to end. Now, I tried to read it, but I can't read legalese, and I got the gist of it. But they said that they thought it was the most humane act they'd ever read because in terms of suffering, it says suffering that the patient finds intolerable. There's no bar of suffering that a patient has to declare or show. If they find it intolerable, that's good enough. And I think that is very humane.
So when people are going through the process, and I suppose it sort of links the last question a bit, but how comfortable are they with discussing their options, any concerns they may have, or do you spend sort of that large amount of time with individuals sort of accessing an assisted death?
I think that as you go through the process, you cover all sorts of areas right at the beginning. So the first time they make their formal request and you accept it, and there's a bit of stuff to fill in on the thing, but then you're mainly answering all the questions. And then the next stage, you have to assess their documents. So you have to see that there's a bit of bureaucratic stuff to go through. Then they have to see the independent consulting practitioner who makes their own independent assessment of all the same things. And then you come back together and you go through the next stage. So they have to do the written declaration and so on. And you talk about how they're going to access the substance. So at that point, you are getting down to the nitty-gritty of the situation. So really, their options of whether they're going to take assisted, whether they're going to have oral administration, where they have complete autonomy, the stuff is delivered to their house, they can take it whenever they like, or whether they're not capable of that, or they'd rather have an injection. So you're getting down to really how they're going to actually end their life. And it's very variable. Some people, they want the autonomy of having the substance in their house, and they might not take it for months. Some people, like, they come and see me and they say, I know I've got, for instance, a breathing problem. They've got COPD and they know it's going to be a horrible death, but they're not there. But they know that in the next few months they might be. Anytime they might have a bad chest infection and go really downhill. So they want to get their ducks in a row, as they call it. They want to go through the system, get everything ready, have the substance there, and then off they go. And I might not see them then. I might not hear until they've taken the substance or died of something else. They might end up in hospital with a chest infection and die, or they might take the substance and then I'll get notified. But then there are other people where I'm much more involved because things are going downhill very, very quickly. And then you try and facilitate getting the appointments in the time and trying to get everything organized. And then you're much more involved. And those ones are much more heartbreaking, I suppose, in a way. Because when someone's going downhill very quickly, the logistics can hold them up, and then you feel bad because you want to help them. That can be very difficult. But at the end of the day, it is satisfying to help people have a choice to die comfortably. Yeah, I have had some that have been very stressful because of the sort of urgency at the end of their life when they're deteriorating very fast. And that is much more stressful, I have to say.
And I assume that takes quite a sort of emotional toll as well, dealing with
Yes.
not only that, but also, of course, generally working as a GP on top. So is that quite a difficult balance almost?
It is. And one of the amazing things about the navigators is that they always say, if you haven't got the time or the emotional capacity, we totally respect you saying no. And that's really important, that they do not put pressure on us. If somebody's going away for a couple of weeks, they might not want to take on any VAD cases because they won't be able to commit to them. If you're off sick or you've got some surgery or something and you know that you're going to be out of action, you have to say no. I'm trying to do GP work at the same time. And if we're going through a spell where we're short of doctors at work, I maybe can't do as much VAD work. I'm not doing a whole amount, but it's a steady amount. But sometimes if it gets too much and you get a question saying, could you take on this role? You have to say no. Because there will be someone else that will do it, we hope.
And something else of interest, I suppose, is in terms of the substance being administered. I know that sometimes it's by a VAD practitioner, sometimes the individual does it. So how important is that choice in allowing people to either do it one of those ways? I know some systems, of course, only allow you to do it one way and just to.
I think the Canadian system is all injection. I think that when they set the system up in Western Australia, they took note of the fact that there are a lot of very remote people. And I think being able to access the substance as an oral substance and take it yourself at the time of your choosing is great. But there are some people who can't do that. They can't open the bottles, or they just can't swallow, or for various reasons, or they're worried that they might mess it up or something. So those people do need to have practitioner as administration. Now, I choose not to do that simply because I don't have as much experience now. I'm de-skilled in cannulation, and trying to cannulate an elderly, skinny person with very bad veins, I would find that incredibly stressful. If you can't get the needle in and things go wrong, that would be very, very stressful. And it takes a long time. It would take a couple of hours out of my afternoon surgery, and I'm always booked ahead. So I choose not to do that. But there are practitioners that will fill in that role. So that's one aspect of the VAD that I haven't been involved in, simply because I'm not good enough. and I haven't got the time to do it at the moment. I mean, they do run cannulation education sessions and so on, and at some point, if I do less GP work, I might consider doing that. I have done assisted oral, where I've helped someone to actually make up the bottles and drink the substance where they've been in a nursing home and not able to do it themselves. Um, and I don't mind doing that at all. I haven't minded doing that at all. And again, that was very interesting because it was a local nursing home, and the patient obviously was in, very bad heart failure, wanted to take the substance. One of the relatives didn't approve of the whole thing at all, but wanted to be there, and then watched the whole thing. And afterwards took me outside and said, "Can I speak to you alone?" And I said, "Yeah, of course." And this woman just hugged me and said, "I didn't realize it was going to be so peaceful. I'm so glad you allowed it to happen." And that was very satisfying, actually, knowing that the relatives had witnessed the death and saw how peaceful it was. Yeah.
So my final question, and one of the concerns that has been raised on assisted dying is, of course, palliative care, and it's the idea that assisted dying would be used to sort of as a result of a struggling palliative care system. So has this happened in Australia, and what's been the impact more widely on end of life care in Australia and on Australia as a whole?
Well, it's an interesting question because whenever VAD doctors have discussed this, it turns out that actually palliative care have always been pleading for more money, and they've actually had even more money since VAD came in. The palliative care system in Australia is run by, well, at least in Western Australia, is run by an organisation called Silver Chain, and they are opposed to VAD as a organisation. But some of their practitioners are not opposed to it, but they can't become involved. But I've got one of my most long-standing VAD patient is under Silver Chain and has lots of input and help from them. And they're aware that she's got the substance and may take it. But I mean, she's actually had it for almost 18 months. And in fact, some of her medications expired and had to be replaced. She wanted the substance because she knew she was anticipating a horrible death, and it hasn't happened. And she's still going, and that's great. And at some point, she will probably access it, or she will die at home, just not wake up one day. But she accesses Silver Chain. Many of my patients have accessed Silver Chain. I don't think it's hampered them in any way at all. So I think that's just a red herring of an argument. It just doesn't apply. And the other one was coercion. Are people going to be coerced into it? Again, I just don't think it happens. Or if it does, it's so minimal.
Well, thank you so much for joining me today and for discussing everything and for taking your time out as well.
Oh, it's a pleasure. I'm always happy to spread the word about VAD because I think it's so important.